Joining us here are 2010 ONS oncology nurse practitioner Pam Viale and also editor of the new Journal of Advanced Practitioner in Oncology. Thanks for joining us. Tell us about the new gig.
Well, thank you very much. I'm happy to be here. The new journal is a publication aimed directly at oncology nurse practitioners, oncology clinical nurse specialists, and oncology physician assistants, as well as any other advanced practice nurse that's working in this discipline. And it's actually the first journal to target this particular demographic, so I'm quite excited to be involved as the new editor.
And it's the new debut here at the conference, right?
It absolutely is. So we are handing out our first issue, and we will be publishing it every 2 months thereafter.
Great. Pam, in looking at testing, what do you feel are the prime-time genetic tests currently being used?
In colorectal cancer, we are actually closer than ever before to the point of giving individualized care for our patients, which is going to be wonderful because we'll be able to avoid toxicity and therapy that's not necessary for patients and give them the therapy that they really need. Unfortunately, we're not completely there yet, but we do have a couple of tests that we're using that are really, I would consider prime time, and I would consider the most important one the KRAS test. It's now endorsed by the NCCN guidelines, and ASCO has come out with a provisional clinical opinion about using KRAS, and it's extremely important. We want to use that test to identify patients that are appropriate to receive treatment with epidermal growth factor receptor inhibitors, monoclonal antibodies. And we have two of those, panitumumab and cetuximab. And that will help us identify the patients that will truly derive benefit from those particular therapies. So that's important to test all patients for KRAS. And I believe the NCCN guidelines state very clearly that we should be doing that. They also call for testing as an option of BRAF. These are both genes inside of the colorectal cancer cell, and BRAF is considered an option to testing with KRAS if you can't test for KRAS or you believe you should go on and do further testing. So I would consider those to be the two most important prime-time tests currently available today in clinical practice.
Can you elaborate on the difference between mutated KRAS and wild-type KRAS?
Absolutely. KRAS, as I said, is a gene inside of the colorectal cancer cell, and it has to do with cellular growth and proliferation. So if you have a wild-type KRAS, that means that your cell is going to behave more normally, and you will respond to treatment, hopefully, with EGFR inhibitor therapy. However, there's about 40% of the patients with colorectal cancer that have a mutated form of this particular KRAS gene. And mutated KRAS means you're not going to respond to those therapies. These are pretty costly therapies, as well as they do carry some toxicity. So it's important to know which patients are going to be responding up front. That's why the test is so important. So the mutators are not going to receive it. The patients with wild type will receive it. Previously, we didn't have information on this particular aspect of these cells, and we've gone back retrospectively and looked at the data of the most important clinical pivotal trials, and we've seen that virtually none of the patients that have mutated form of KRAS are responders. So they should not receive the therapy, and we're fortunate enough to be able to test and identify those patients up front.
What tests are there for the prediction of toxicity?
Fortunately, we have a lot of therapies for colorectal cancer patients. Unfortunately, some of them do carry toxicity. It would be ideal if we could identify which patients are going to be at risk for increased toxicity with certain agents. We don't have tests available for all of the drugs that we use for colorectal cancer, but we do have a couple of tests that are used in clinical practice. I won't say they're standard of practice, but you will see them being used. One of the drugs that's very important in the armamentarium for metastatic disease is irinotecan. There's a small percentage of patients in our population of colorectal cancer patients that are at risk for increased toxicity. These patients have the UGT1A1 star 28 allele. They're homozygous for that allele, and they will have increased toxicity. So if we could identify those patients up front, we may be able to still give them the drug, but maybe give it to them at a reduced dose, or perhaps avoid it altogether. So there is a test that's available that physicians or clinicians can order for their patients to determine if those patients are homozygous for that UGT1A1 star 28 allele and determine whether or not they might be at risk for increased toxicity. However, I wouldn't consider it standard of care, but it is listed in the NCCN guidelines as a potential for checking. The other toxicity that I think is important to remember is with the 5-FU or oral 5-FU agent capecitabine. So those are two important agents. We use them in both adjuvant disease and metastatic disease. There's a small percentage of patients, again, who could be at risk for increased toxicity. And so we want to identify those patients that are DPD deficient. That's dehydrogenase pyrimidine deficient. So if we can determine whether or not those patients have a DPD deficiency, we might be able to avoid 5-FU or maybe even give them a reduced dose to avoid toxicity. It's an important toxicity because there are patients that have been reported in the literature to have had a lethal outcome with DPD complete deficiency. So I think that maybe they're not standard of care, but we do consider them as useful tools in the identification of patients who might be at risk for toxicity.
Pam Viale, thanks for spending some time with us, and best wishes in your new position as editor of the new Journal of Advanced Practitioner in Oncology.
Thank you very much.